Well, there you go. So everything you say now, everybody else will hear. So let's just get my screen back up here. All right, so today we're going to talk about some toxicology and some substance abuse, kind of just narrow it down to the basics of what you got to know and hit the highlights of toxicology, toxicological emergencies. Make sure you do a sign-in roster for each of your departments out there so you get credit for being here. So, well, we can start with tell me what we're talking about. Tell me what we're going to talk about today. Toxicology, that's good. And substance abuse, you guys are awesome.
Anything that affects the body, physiological manner.
Okay, so Don is saying anything that affects the body in a negative or physiological manner. What are we talking about? Overdoses, exposures,
Drug and alcohol.
drug and alcohol. Hey, we kind of put all these things together. These are patients. Can be some challenges to challenging patients to deal with. Here's some examples. Right, so a 73-year-old man who passed out after taking too many of his pills. Is that an option? Is that a toxicological emergency?
Yes. Can be.
Yes. Can be. Can be. We're going to look at some examples here. Intentional or unintentional, right? So it tends to deal with some sort of outside of the body issue. Doesn't have to be outside of the body. What about a 19-year-old female vomiting after eating at a food truck?
Normal.
Which truck?
Which truck? Could be very food dependent. Could be what?
Allergy dependent?
Could be food poisoning. It could be food poisoning. Could just be could be the cold or flu, but we don't know. A migrant worker sneezing after returning from the fields.
You just saw Trump.
Chemicals.
Could be chemicals, yeah. Could be chemicals. Could be an underlying medical emergency. Or a toddler has burns in his mouth after drinking laundry detergent. Right. All these examples are very possible. They could come over any time of the day. They could come over today, tomorrow, tonight. These are all toxicological emergencies. They're going to present some challenges for us. So I know most everybody got logged in already. We're going to make sure everybody's in and do our sample question. So we have everybody. We got 4 of you over there, right? I think I see all 4 of you. And then 6, 7, 8. Jordan on here. Missing one. Is there one person not going to play? There we go. All right.
We got Colin.
Okay. Getting set up?
Yeah, he's getting set up right now.
Okay.
Andy's re-entering.
Okay. Then I got 4 there, 4 here, and 2 over the other station, so we should have 10.
He's got an iPhone. It's going to be a struggle.
Yeah, the easiest thing is actually put on the app. All right, perfect. So here's our sample question. If you remember right, it's like bar rules. You're going to see the answer or the question. It's going to count down, give you select the right answer. On your phone, you're going to see the 4 colors and the 4 different shapes correspond to the colors and the shapes on the screen. Here's your sample question. Time's up. We only had one person who completely, I'm sure, guessed it right, and let's whoever do that. It is actually Greenlandic, is the official language of Greenland.
That was a trick question.
It's not a trick question. Jordan's topping the charts already for us. All right, so that's what we're going to do. As usual, we just got a couple slides. We're going to talk about stuff, and then we'll do some follow-up questions. As usual, we always talk about epidemiology, right? How much of a problem is this? There it is. Those numbers, so those are 2013 numbers. They haven't changed since 2013, right? What is the most, if we look at teens and adults, what is the most common, and we call it, the CDC calls it exposures, or I'm sorry, Poison Control Centers call it exposures. What are the most common things we're exposed to?
Environment.
Environmental
Allergens.
allergens.
So we're actually looking right up here in the upper right-hand corner. It's analgesics. Let me get my little laser pointer here. Right here. Right, so we're talking about teens and adults. Top 5 human exposures is analgesics. So these are things that are coming from poison control. So these are patients who were admitted for poison control issues. Guessing looks like we took probably bee stings out of there, because you're probably right that there's probably more of those. But as we're looking at exposures by drugs, it's analgesics in the adult population. When we get into teenagers, we're looking at antidepressants. Otherwise, well, there's bites of envenomation. So no, it's actually overdosing on pain meds. When we look at these younger kids, and we know this, right? Anywhere between 6 and 12, what are they exposed to? For body airway, right? Sticking things in their mouth. And then we get down to little kids. This is little kids eating healthcare products. Right? So it's eating lipstick because it looks like candy kind of stuff. Right? Overall, it's analgesics. And we're fairly aware that pain medicine here is an issue. So you're called out to somebody who's exposed to something. We'll talk about our traditional, so in this case, we're not going to talk about bee stings. We're going to actually talk about envenomations and stings towards the end. But you're called out to an overdose. Who are you going to call? Thank you, Ghostbusters. Who do you call after that? Okay, ambulance is on the way. So you got somebody who's exposed to the chemical inside of a chem stick. Got a 3-year-old who drank the bright yellow stuff out of a chem stick. The toxic?
Poison control.
Right, so I heard somebody say poison control, right? You don't know. By the way, the stuff is actually non-toxic, in case you want to know. But the substance inside of a chemical stick, we don't know what it is. You can't know every single poison that's out there. So we tend to call poison control. Right, so it's the American Association of Poison Control Centers. I was trying to find how many there are. Oh, there it is. There's 55 poison control centers across the nation. Does anybody know where our nearest one is? I heard Milwaukee from here.
Yeah, I'd say Milwaukee.
You got a second for Milwaukee? It's actually Madison.
UW, isn't it? Yeah.
Yep.
So I thought
Yep.
UW
UW
Hospital.
Madison is actually the poison control center for the state of Wisconsin. And it's not driven by states like that, and it's the same number across the nation. Right, you call that number, and it directs you to your nearest poison control number or poison control center. Not a bad thing to actually put in a phone, right? We have them in all of our rig phones because you pick that up, right? 1-800-222-1222, and you're going to get the poison control center that's closest to you. Like I said, ours is actually UW-Madison. So you call that 24 hours a day, 7 days a week. There is a pharmacist, or I believe it's actually a pharmacist or someone on the pharmacy staff that answers that phone, and they're going to ask you lots of questions. What did they take? And they're sitting in front of a gigantic database that they're going to be able to tell you signs and symptoms to look for. And in pediatric patients, even some adults as well, they're going to ask you patient's weight, patient size, how much did they take. We'll talk about some of those assessment things here in a minute, but they will give you some guidance on what you should do, right? Induce vomiting, don't induce vomiting. They don't need to be transported. They need to be transported. Another advantage of them having here in Madison is if you decide you need to transport this kid, right, who accidentally took the contents of a chem stick, right? A 5-year-old, 22 pounds, I'm going to take him up to Merritt or take him up to St. Mary's. They actually proactively will call the hospital you're going to and tell them that you just had this great conversation with them on what they took, what the size was, how long it was, and what that hospital needs to do so that the hospital is actually prepared for you to be there. So a great asset that's available, it's available to every EMS actually lay people can call it, but it's available to everybody to give them a call as soon as you identify what that substance is. How do those substances get in your body? There's 4 ways, Patrick. Inhalation is one of them. Absorption, injection, ingestion. Yeah, it's the 4 ways right up there. So tell me about ingestion.
Drinking it, eating it, whatever.
Something through the GI tract, right? It is ingested. What does this tend to be?
What
Give me
is
an
it?
example. Give me an example of some sort of ingestion.
Tide Pods.
Oh, there we go.
Tide
Alcohol.
Pods. There we go. Yeah, Tide Pods, the latest
Cleaning
example.
supplies, cleaning supplies.
Yep. Alcohol. What else was it? Drugs, alcohol. Yeah, anything that goes down the GI tract is ingested. How fast do those work? Okay, it can depend on what it is. Tell me about absorption through the GI tract. Can it differentiate between Chex, cereal, and bleach? Say, no, I know Chex cereal is bleach. Chex cereal should be absorbed and bleach shouldn't be. No, right? The ingestion, it's indifferent, just like everything else in your body. Whatever goes down, it is going to be absorbed. So that can present a challenge for us. Now, the GI tract, though, it can get absorbed. Things that have to go through there, remember, have to get broken down. Everything in your body has to end up in a liquid state in order for it to be utilized somewhere in the body. So it can take a little bit of time for that ingestion to occur. And then it can ingest, depending on where it is, it's the stomach. The small intestine is actually what absorbs even most of your food, is where most of the absorption occurs, in the small intestine. What did you learn, maybe, depending on how old you are, when you took your EMT class? What did you learn was a treatment, that used to be a treatment M2As for an EMT basic? It still is.
Activate charcoal.
Activated charcoal, right? It's still in scope of practice. Nobody carries it anymore. Even the last time we carried it, Ross is the only one I knew gave it to anybody.
That was before ketamine.
Yeah, there you go. Now we got better drugs. Charcoal wasn't an antidote, and if we know the drug, we'd love to get an antidote to go in there and treat it, but charcoal wasn't an antidote. All it did was actually bind to whatever was in your system, and usually charcoal also in that container had some sort of diarrheal incentive, right? So that charcoal went in there, bound to whatever it was, and then you spit it out pretty gosh darn quick. So that's what we used to do, that for the GI tract. Now there was still is some issues with giving those patients charcoal. It's got to be a certain amount of time, right? Because once it gets in the body, once it gets absorbed, charcoal is not going to do anything for you. But it's still one of our options for as far as a treatment. What about inhalation? You think of an exposure you get from inhalation, intentional or unintentional. What job are you in? Smoke, which contains
Carcinogens.
carcinogens, carbon dioxide or carbon monoxide, cyanides. You going over to the pool if you got a bunch of people coughing without your SCBA on? Chlorine gas. Yeah, you kind of know where I'm going with this, right? So then we got a couple different, ways we can go down there. But chlorine gas is an inhalant, but it can cause immediate cellular destruction. How fast are things absorbed when you inhale them? Very, right? Directly into the bloodstream, right? We give you oxygen and we get your pulse oximeters up pretty quick. Nitrous, right? Latest and greatest things out there in the southeastern kind of corner of the county. Nitrous, fairly instantaneous pain medicine when you get there and goes in and reacts. So inhalation reacts very quickly, gets absorbed into the bloodstream. What about absorption?
On the skin.
Okay, this one's a little tougher. Yeah, it gets absorbed, it puts on the skin. Your skin doesn't differentiate right, what's on there. It's going to start absorbing it. This is one we tend not to think about because most of them tend not to be like threatening. Hydrocarbons is the biggest example. Hydrocarbons and solvents. So this is gas, right? Gas, mineral spirits, all of those things that actually cross over that barrier in your skin. Hydrofluoric acid, bases and acids, slowly get absorbed through your skin as well. Hydrofluoric acid being a huge one. And most people, does anybody have hydrofluoric acid in your home? Doubtful. It's used for etching. All right, especially in large industrial purposes, but on a smaller scale, it's used for etching of glass and metal. But it's actually, you can't feel it. Right? So it crosses over your skin, it gets absorbed into your skin, it actually starts creating these huge chemical reactions in there because right, it sits in those inert gases, and fluorine, it's actually very active, causes some pretty significant burns. What about injection? Needles?
You can have a pressure injection of a liquid,
Sure.
like a high pressure hose, hydraulic hose.
Yeah.
Injection.
That is a huge, that's not a huge one. It doesn't occur very often. But yeah, you can get an injection with the Hurst tools, right? You get hydraulic fluid in there. How caustic is hydraulic fluid?
Stuff that's in the hydraulic.
Yeah, extremely. Yeah,
Worse than hydraulic.
yeah. Hydraulic fluid, okay, is extremely caustic. And as you said, even a small hole in a line is under the pressure that it's going through is going to shoot through. It's actually going to make an injection. It's going to shoot a hole through your skin with liquid under such pressure. As much as it actually, when you initially look at it, said, "Wow, that kind of hurt. Doesn't feel too bad, though. I shouldn't go in." If we don't transport those patients, they tend to lose limbs because it sits inside of that small hole and actually continues to burn. It's very caustic and will cause a lot of tissue destruction. Otherwise, bees, stings, and we talked about actually submitting drugs themselves or injecting drugs themselves. So, question. Injection, absolutely. Ah, because it's going through the GI tract. Right. GI tract, so that's ingestion. We know who it was. It's always a trivia question. That means that I know this set of questions is over.
Yes. Fiddlesticks.
Yes, true.
You were such a guesser. They just said that it's going on.
Ooh, on fire right there.
Yeah.
All right, we'll see how well this streams for us. Of course, it worked yesterday. Oh, the sound might not work in this room though, right?
Great movie.
Oh, this is great.
Go home, jerk off, and that's all you're gonna do.
Can you guys see it?
Yeah.
Okay. We're talking about overdoses.
Oh.
And Mia, listen, I gotta go. Right? Oh, Jesus Christ. Oh, fuck me. Fuck me. Oh,
There's some inappropriate language.
we're getting out of here. We gotta walk now.
Bill's virgin ears.
It's okay. John will go to church tomorrow for all the swearing.
Don't fucking die on me, Mia. Answer. Hold hands, you loud bird. Fuck you, Lance. Answer. I can hear it.
Why you tell those fucking assholes never to call here this place?
Yeah, I told him. And that is exactly what I'm going to tell this fucking asshole right now. Hello, Lance! Vincent! I'm in big fucking trouble, man. I'm coming to your house. Whoa, hold your horses, man. What's the problem? I got this chick, she's fucking ODing on me. Well, don't bring her here. I'm not even fucking joking with you, man. Do not be bringing some fucked up poop onto my house. No choice. She's ODing? She's fucking dying on me, man. Okay, well then you bite the fucking bullet and you take her to a hospital and call a lawyer. Negative. This is not my fucking problem, man. You fucked her up. You fucking deal with this. Are you talking to me on a cellular phone? I don't know you. Who is this? Don't come here. I'm hanging up the phone. Prank caller. Prank caller.
You missed the best part. Yeah. So what happens? It's the intracardiac. Yeah, we'll get the video clip fixed for tomorrow. So that overdosing, right? Just an example of what we see. So how do you assess and manage a patient with toxicology issues, overdose issues?
Airway.
There you go. That's the primary thing is what?
Scene safety
For who?
for us.
For us, right? Always responders. That's the first thing you learn in class, right? Hands in the air like you just don't care. You're like, hey, BSI and the scene is safe. So that's huge to make sure that we are the ones who are safe, even if these patients are waking up. What is the next most important thing? So we're going to take care of our patients, right? We got to go way back to those basics, that airway, breathing, circulation. Patients who are not breathing, start breathing for them, and we start managing those airways. How about when it comes to figuring, what is the, it's that question that always gets you in the EMT basic exam. What is the definitive care for this patient who overdosed? We need to get it what? That chem stick kid, what does that kid need? Or the kid who takes too many hydrocodone, the one who takes Tylenol. We're trying to figure out what ultimately happened to them, right? What did they take? How much did they take it? Because we need an antidote for that, right? We need to reverse whatever it was. Who's going to be the best person to figure out what this patient took? The hospital or you?
Us, because
Check the clues.
Yeah, that's it, right? What you see in the scene. It's going to be the clues that you see in the scene. When we bring this patient off to the hospital, even an unresponsive patient, right? What information is that hospital going to be able to get? Well, what we gave them, but going to write an unresponsive patient, how can they talk? They're going to be able to tell them what they took, right? But what do we see? Sure, we see empty bottles. Right? We see syringes, we see empty bottles, we see whether it be alcohol, whether it be prescription medications. How fast does a toxicology screen come back at a hospital? Not. Like, not. They're really expensive, and they can't just do like, all right, unlike television says, that I can't just draw some blood and go, hey, we know what you took, and here's the antidote. That doesn't happen, right? Hospitals don't have the ability, or don't, dollars-wise even, don't have the time to go, let's just take this and find out which one of the 3,552 medications you took and what your levels are. We are a huge component in finding out what these patients ultimately took and how much. How are you going to figure out how much they took?
Look at the date on the bottle when it was refilled.
Sure. So we're actually going to look at that date and find out, if I'm authorized one refill, it was filled yesterday, there's 30 of them, and then I'm supposed to take 2 a day. How many are left in there, which means how many did you take? If you took them as prescribed, right, there should be 28 left, hence you overdosed on 28 pills. We suspect. Is that always the case? Did they always take them?
No.
No, not always. But to the best of our knowledge, we're just going to assume they did, right? It's entirely possible they flushed them all down the toilet. Entirely possible they shared them with their friends. That's what we're going to do. But otherwise, it's very much, for most of the treatments we're going to see here, is back to our basics. Just managing that airway and supportive care. Now we're going to hit kind of a couple of highlighted medications, and then we're going to talk about syndromes, or we call them actually toxidromes as the medical term for them. There's kind of this grouping of signs and symptoms that match up with different types of medication exposures, so we can help to identify what the problem is. So let's look at our first one. Somebody want to read that for me?
You are a Med 118 responding to assist the local rescue unit with an unresponsive 14-year-old. The rescue crews reports that patient was found in the bathroom of the village park by the public works employees, just starting their maintenance of the park in the morning of 0900. There were no bottles or medications found around him. Primary assessment shows the patient unresponsive, breathing slow and shallow, and a slow heart rate of 54. His skin is cold to the touch, and there's evidence of urinary incontinence or vomit.
So, what are your primary concerns, and identify what your first priority is?
Scene safe.
All right, so is the scene safe? Probably going to be safe for us, although, you just find somebody down in the middle of a park, who knows what they could have been exposed to something.
Correct.
What else?
Airway, breathing, circulation.
Okay, which of those is your primary concern?
Airway.
Why?
Vomiting.
Why?
Vomiting.
Okay. What else? I vomit.
Well, he's got shallow breathing, so we got to worry about his airway there too. Breathing shallow.
Okay, so we
That's
can
the
maybe
system.
shallow. We can put airway and breathing probably together with this one, right? So is he protecting his airway?
Probably not.
No.
Probably not. Unresponsive. Yeah. Unresponsive and vomiting, probably not protecting his own airway. Is he effectively breathing?
No.
No.
No. Slow and shallow. What's that heart rate? 54? Right, so
Yep.
a healthy active 14-year-old, that could be actually fairly normal in him, but number one cause of low heart rate?
Not enough cholesterol.
Maybe.
Beta blocker overdose.
What is this kid's issue? What did we just talk about? He's not breathing, right? Number one cause of bradycardia in any patient population, hypoxia. He's ineffectively breathing. You hold your breath for long enough, your heart rate starts to go up and then it starts to go down, right? Number one cause of slow heart rate in any patient population is bradycardia. Check that airway first.
Check for hives. I'm not sure. I'm kind of throwing my ideas out. 14-year-old, kind of young for not impossible, but I kind of looking at it as young for heroin.
Okay.
I'm thinking unresponsive, breathing slow, shallow, maybe anaphylaxis, but I don't know.
Okay. So one of the concerns, potentially anaphylaxis. It would still be weird to be in the public park bathroom at 9 o'clock in the morning, responsive in a complete anaphylactic reaction. I mean, the whole thing is weird, right? The whole thing is weird. So what is your first priority? You said manage that airway, right? Clear it, manage that airway. Right. We can bag valve patients forever. What other information do you want to know? I heard here. So we're going to look for hives, other environmental clues. Right, so I'm looking for hives. I don't see any. We already looked around here. No bottles, no medications around him.
Check his arms.
Needle tracks.
So we can look for needle tracks.
Anything in the vomit?
No pills in the vomit. Vomit's actually, in this case, the vomit's actually fairly dried. And his skin is cold, which means what?
He's been outside a long time.
He's been here for a while.
Is he stiff?
He is not stiff. He is not stiff, right? He's cold, but I heard what? Looking at the vomit for pill fragments? No. Oh, that was it. Check his eyes. So they are reactive but slow to respond. But they're not dilated, they're not constricted. That is a huge assessment, right, in looking at toxidromes. Medical alert bracelets. What other stories do we have? So what is our treatment plan for this kid? Drive fast.
Protect the airway, keep warm.
Check blood sugar.
Check the blood sugar, right? Any patient with altered level of consciousness.
Put a nasal airway in after we clean his airway out.
Perfect. So nasal airway, bag valve mass ventilation. Check blood sugar is normal.
Okay.
Warm them up.
Yep.
Start warming them up. Right. Another, probably second cause of bradycardia. Cold, hypothermia. Anything else?
Head injury, maybe?
So really good patient assessment, right head to toe. Did he fall? Did he collapse? Did he seize? Or do we see any signs of head trauma or any other trauma? Could this have been an assault? Right. So this is another huge assessment. You have to do that head to toe. We don't necessarily need to expose him, but there's need to expose him. Could this have been a sexual assault? Right, that we don't think about. And as we're trying to warm him up and we keep him fully clothed, then we find out there's dried blood all over his pants. Right, that's an assessment tool. Anything else that we want to do for him?
Get him to the hospital.
Yeah, so fairly rapid transport.
Grab and go. Yes.
Get him transported. So this is actually a real call. He was actually just drunk. So that was the only thing wrong with him, but he'd been there since 2 a.m. And all of his friends. This has actually occurred in Mount Horeb. Anyone who lives. Yeah. Yeah, there's actually some good video footage of his friends coming to check on him a couple times since 2 a.m. before the park workers finally found him at 9. And I think his blood alcohol was a 0.2 something almost 6 hours later. He was really drunk. Yeah, right. So this is a long one, right? Rescue 45 dispatched to 19 Meadow Trace for a patient with an unknown problem. You meet a police officer out front who says it's a 72-year-old man who tried to overdose. Told the officer has been suffering from severe depression since his wife died about a year ago. Sitting in the living room crying, he's cooperative, continues to apologize for bothering you. Says he intentionally took 10 of his prescriptions, Zolpidem, and then got scared and called 911. Not in any distress other than very emotional, and he actually walks to the ambulance with you. Right, going to do what we normally do. Patient's vital signs 84 regular, respirations 12, beautiful O2 set 96%, lungs are clear, BP 164 over 92, cardiac monitor, normal sinus rhythm, a little bit of a wide QRS, blood sugar's 142. He's on a Tenolol for hypertension, inhalers for COPD, admits to drinking some beers, right? They always swallow their pills with alcohol. As you're transporting, you noted that his level of consciousness starts to decrease. He becomes more difficult to arouse. His respirations are becoming slow and shallow, and you notice that he is becoming incontinent. What are your primary concerns, and what's your first priority?
What's the open?
So identify what the medication is. Ambien. Anybody take Ambien? Know somebody who takes Ambien? What do the commercials tell you about Ambien?
A list of about 60 things.
Okay. There's a couple big ones now, though, based on this to take notes. They say, and the commercial even, right? It says, after you have taken your medication, be what? Be prepared to?
Sleep.
Go to sleep. And make sure that you can what? Be asleep for 8 hours. Because what happens? The commercial, it actually does not lie to you. But after you take your Ambien, how fast does it work? Real quick, right? Real quick. Especially 10 of them happen real quick. And what are you going to do? You're going to sleep for 8 hours, right? Just like the commercial tells you. So what are your primary concerns with this guy?
Airway would be probably the number one.
Yeah, he's really good at sleep. So we're back to my airway issue, right? So we looked at our assessment. He's unresponsive. Are you going to reverse this? I actually don't even know if I was going to do some research. I don't know that there's a reversal agent for Ambien.
Airway watching his vitals.
No, it's other than we're going to watch his vitals, and I would have to see what class it even is. It's a weird sleep agent class. But because he's altered level of consciousness, his respirations are slow and shallow, right? We just said managing that airway, he's going to start to bring you down. What does he have a history of?
Depression.
Depression.
COPD, so you got some issues there.
Sure. So we're going to assume that when he was cooperative with us, he told us all this information. We're going to assume he didn't overdose on any of those other medicines. What's the appropriate care for this guy?
Assisted breathing is necessary.
Supplemental oxygen and
O2 and monitor his heart rate and his vitals.
Yeah. We're going to keep watching the heart rate. We're going to give him some oxygen. We're probably going to assist respirations. Based on his unresponsiveness, he probably may or may not have a gag reflex based on what 10 Ambien are going to do. So that might be something, right? Some aggressive suctioning, determine if he's got a gag reflex. My guess is probably at this, but again, real case study. He was asleep by the time he sat down in that ambulance, and it happened that fast.
There's an antidote.
There's an antidote? Okay.
It's called flumazenil.
Flumazenil.
Benzodiazepine receptor antagonist.
Okay.
But that's not something, obviously not something paramedics here.
We don't because it comes with, it's in scope, but we don't because there's some other issues that go with it.
Gotcha.
So that's what we just need to, this is back to identify what he took and support that airway. Again, probably going to have this guy will probably have a not intact gag reflex. We'll just continue to beg for him.
How long after he took these 10, we have the possibility of this guy going into cardiac arrest?
He shouldn't go into cardiac arrest because of the overdose of if this is truly benzos. As long as we manage his airway, we're going to just breathe for him. It's just going to shut his airway down. It's going to put him into respiratory depression. May, to a lesser extent than narcotics, will bring his blood pressure down. So that may be something we'll need to be watching as well. It shouldn't do anything. Why does he have a wide QRS? COPD won't call it, but we don't know. Can it be normal to have a wide QRS in you and me? Absolutely. Right? He's 72 years old. It's entirely possible he's got maybe a bundle branch block. Now we're going to visit some medications later that cause wide QRSs, but as long as this is the initial rhythm we see and it didn't get any wider and it didn't change, we're going to call it normal. But there can be some other causes here. Somebody read this one for me.
Rescue 190 and Engine 15 are dispatched to 1301 North 8th Avenue for an unconscious female. The crew is familiar with the address from previous encounters for cutting. Police indicate the scene is safe to enter and crews find a 24-year-old female on the couch. Her boyfriend is present and says that she called him about an hour ago and told him that she was going to kill herself. On the floor is an empty bottle of nortriptyline and was filled yesterday, as well as multiple empty bottles of alcohol. Primary assessment shows the patient to be unresponsive, breathing slow and shallow with a rapid heart rate.
Back to this. What are your primary concerns and what's your first priority? Scene safety for us, right? Because we've got a known cutter. So at some point, we fairly know these patients. She's never been homicidal in the past. But that doesn't mean today is not going to be the day she's going to take somebody with her. But so scene safety, right? Whereas we're not called for a cutting. We're actually called because she's unresponsive. What else? What are your other priorities?
Airway.
Yeah, back to before. Unresponsive patient, right, with slow, shallow respiration. So we're going to be breathing for her. Now, this patient actually has a rapid heart rate. Does anybody know the class of nortriptyline or what is nortriptyline for?
Antidepressant.
It's an antidepressant. Anybody know the class of antidepressants? Well, 3 big classes out there. We don't use a lot of these anymore. We call them tricyclic antidepressants or TCAs. There is actually a specific protocol. There's one of your homework items. There's a specific protocol for tricyclic antidepressant overdoses. If she lies there on the floor long enough, this will kill her, right? These patients who overdose on TCAs will die. So the pathophysiology behind it, essentially it works, how it works up in the brain, it causes widening. Ultimately, the side effect of one of the TCAs is, here's that example of this actually causes a widening QRS. It messes with some electrolytes to cause a delay in ventricular repolarization. So what was a narrow normal QRS complex on your monitor, you're going to see start to get wider and wider and wider and wider. And ultimately, they go into VFib and VTAC. Because as it starts to change that conduction delay and it actually starts messing with your respirations, it actually also changes your pH. And patients become very acidic. Right? That acidic, then it just steamrolls out of control. What's the appropriate care for this patient?
Bicarb.
Sodium bicarb. You carry that as a first responder or BLS agency?
No.
No. So my last 2 patients could BLS, I mean, other than it was an unknown, could BLS manage those 2 patients? Was ALS going to do anything different?
No.
No. Other than fluids resuscitation and advanced airway management if you needed it. This patient absolutely needs ALS. Right? There are specific ALS interventions that are going to save this patient's life. Because we carry bicarb. What bicarb does is it's a buffer it's a buffer. So that as the pH gets more acidic and we start to see these EKG changes, we give these patients buffers to bring that pH back into normal to react with that. So this truly saves that life. All right, just a quick down and dirty of a bunch of other toxins that we're going to talk about here, or we'll review. You're very familiar with carbon dioxide and cyanide. They react the same. Where are you going to get exposed to those?
Fires.
Smoke and fire, right? Predominantly, that's where you're going to see it at. What else we can get carbon monoxides for? We're kind of getting towards the end of the season, but furnaces, right? We've been to how many construction sites where it was cold outside, so we brought a salamander inside in the basement and closed all the windows because it was cold. Right? Generators inside, running tools inside. Anybody ever take the little CO monitor when you're checking the tools inside without opening the doors and you get to watch it alarm? Let's always make sure our CO, when I hear you running the engines out there, I go make sure that ours work on our jump bags because it always gets up higher. Carbon monoxide and cyanide. What is the treatment for them? Yeah, it is that simple, right? How do they work? They have a greater affinity for hemoglobin than does oxygen. So both of them in their own way bind with hemoglobin. So the way around it is actually to essentially supersaturate with oxygen. To a limited extent, you're not truly increasing the partial pressure of oxygen, but by supersaturating it, you're actually bumping it off. To truly increase partial pressures of oxygen, patients need hyperbaric chambers. So based on levels that they draw at the hospital or kind of different how things present, a lot of pregnant patients, fetuses, unborn babies actually have a huge, much even greater than adults, greater affinity for carbon dioxide and cyanide. So any pregnant patient, especially exposed to carbon monoxide and cyanide, needs to be transported, and odds are going to a hyperbaric chamber because it really affects developing fetuses. Caustic substances, we're talking about acids and bases, right? Whether this is ingested, now if it's topical, what are you going to do? So it's on your skin. It's on your skin.
Wipe it off. If it's powder, wipe it off.
Absolutely. We talked about the burns, last couple months ago. So if it's a dry powder, you're going to wipe it off. If it's an acid, are you going to find a base to put on it? Or if it's a base, you're going to find an acid to put on it? No, right? We don't like to make chemical reactions happen on the skin. Most of them create heat, resulting in bad things. But we're just going to try to neutralize it, which is essentially copious amounts of water. Right? That's what we need to do with those. Now, what about ingestion? I kind of have mentioned it in the past, right? Poison control is going to be your biggest friend on ingestion on any of these things, plus treating signs and symptoms. Based on what they ingested, be it a strong acid or a strong base, two different things happen. Acids cause what's called coagulative liquefaction, which actually means bases, when they come in contact with a cell, it destroys the cell, but it destroys the cell and essentially creates a gelatinous existence to it, which means that it's somewhat self-limiting, right? It's still going to be painful, still cause a lot of damage, but it's self-limiting, versus bases, which cause necrotic liquefaction, which means bases actually continue to destroy cells. They don't actually create this gelatin. They essentially just disintegrate the cell, and it continues to burn. So bases actually cause significantly worse burns than acids do. A significant esophageal exposure to an acid or a base is usually fatal, just because there's no way to stop it inside the body. And then once you eat through the wall of that esophagus, you get all the contents and they're released, and these patients just get massive infections and die. Hydrocarbons, we said those are actually my carbon-based fuels. So it's paint thinners, gases, kerosenes, all those things actually, in the long term, cause carcinogens. In huge amounts, they can cause neurologic deficit, but most of the time we're going to just, significant copious amounts of water is going to resolve that. Antidepressants, we already talked about TCAs. The other two that are out there are called MAOIs, so it's called monoamine oxidase inhibitors, or SSRIs, selective serotonin reuptake inhibitors. Those are what you're going to see more commonly prescribed these days because they don't come with the side effects that those tricyclics did. Based on those overdoses, they don't have, like I said, they don't cause that fatalness of it. So the signs and symptoms of some sort of antidepressant usually is going to mess with the neurologic function. So there's going to be confusion, anxiety, possible hallucinations involved with those. Salicylates and acetaminophen. What's a salicylate? Aspirin or NSAIDs, right?
Pain relief.
Yeah, my aspirin, my ibuprofen, acetaminophen is another name for Tylenol. Right, both of them patients can overdose on. Aspirin tends to be, I want to call it fairly benign in huge amounts. Right? It's aspirin ASA, acetylsalicylic acid. In huge amounts, it can actually cause your body to become acidic. Got to be some pretty significant amounts. Acetaminophen, on the other hand, actually has some overdose doses to it. It's about 150 milligrams per kilogram. Who do we see overdosing unintentionally on acetaminophen?
Unintentionally?
Unintentionally gets overdosed. It was actually on News 15 last night, I think, 2 nights ago. Children, because everything has Tylenol in it. Right? So they give them children's cough medicine with Tylenol, and then they have a fever, so they give them Tylenol, and then they give them something because they got a runny nose, and it has Tylenol in it. So they don't actually add up all those individual medications that have Tylenol in it, and they actually reach toxic doses of Tylenol. Unfortunately, you don't really realize that you've reached toxic doses of Tylenol until these kids have some problems in a couple days from now, and then they're in liver failure at like 4 years old. Right? So over the long run, acetaminophen is actually very toxic to the liver. It's hard to filter out. There is an antidote for acetaminophen for a Tylenol overdose. It's called Mucomist. It's actually a nebulized medication. We don't carry it, but a recognition of it. One of the metals we refer to here is called lithium. Anybody know what you use lithium for? Yeah, it's actually for bipolar manic depressive. And it truly is the metal lithium. Lots of side effects to it. You can overdose on it and again cause some pretty significant dry mouth, nausea, vomiting, confusion, and tremors, but it's very effective. So I don't want to call it a treatment of last resort. There's lots of patients out there on it because it's effective when it works. Unfortunately, lots of side effects when it doesn't. Foods and plants, so this could be actually food poisoning or patients who are huffing. These kids like cool puffballs, right? Let's see what happens when I sniff puffballs. They're very creative, I'd say. Anybody know the number one food poisoning out there? Not as far as allergic reactions, but as far as the cause of food poisoning. Botulism is actually still our number one cause of food poisoning, followed closely by salmonella. But they're just regular bacteria that normally live in fairly low quantities that when they get into that great food, they cause some pretty significant. And it's nausea, vomiting. You got to trace back based on history. Right? Where have you been? Where have you eaten? Has anybody else been sick? Common place. Other prescription medications. Somebody brought up beta blockers earlier. So that's what their prescription medications. We've talked about beta blockers in the past. Those are those OLOL drugs, like our patient who is on atenolol. All right, why do patients take atenolol? Why did that guy take atenolol?
Blood pressure.
Blood pressure medication. Right? So they take that because they take too many blood pressure. So even unintentional overdose of beta blockers. So an unintentional medication to lower my blood pressure. What's probably going to be the side effect? Probably going to have too low of a blood pressure, right? Not reaching too far out there. Patients who normally have high blood pressure, they take it to lower their blood pressure. If they take too many of them, they get too low of a blood pressure, or they actually get too low of a heart rate. Right? So think of knowing what the medications, what do you take this for, right? And I take too many of them, it kind of breaks its way down. Now, cholinergics and anticholinergics. Cholinergics is back to my pesticides. or organophosphates, that's that nerve agent poisoning, and anticholinergics, that's actually like antihistamines, like Benadryl or those other inhaled medications. Tell me about, you learned it in basic class, right? A cholinergic or a pesticide overdose. What are the signs and symptoms? I heard it. What?
Sludge 'em.
Sludge, yeah. Or there's a couple different words you can put in the end of it, or a couple letters you can put in the end of it. But sludge, what's it stand for?
Salivation, lacrimal, urination, defecation, gastritis, and emesis.
Yeah, essentially anything. If you have a hole in your body, something is coming out of it. Right? That's what cholinergics are. The anticholinergics suck you up the other way. Right? They turn your skin hot, red, and flush, and make you very, very dry. So you can, as you were kind of trying to figure out what these patients took, good toxidromes is what those are.
Hey, Patrick,
Yes.
can we just go back to the beta blockers?
Sure.
So just remember, some of the beta blockers are excreted through the kidneys. So if you have those patients that have the LOL drugs or the beta blockers and have kidney issues, you notice blood pressure, maybe it's the drug that's not being excreted through the kidney. So I've had that patient before, and he couldn't understand why somebody had a low blood pressure and she was overdosing and she took her medications normally, but over time it wasn't being excreted appropriately through her kidneys. So just kind of keep that in mind when you look at patient's history and other medications they may take.
That makes sense?
Hello.
Lots of reasons patients can overdose unintentionally, and that's because they're retaining more medication than they should. So unintentionally.
Older people too may forget that when take them again.
Absolutely. So you get a patient who's feeling faint and dizzy, weak, faint with low heart rate, low blood pressure, and you put them on a monitor, like what medications do you take? We always follow that up with, do you take them like you're supposed to? Right? You didn't take too many. Well, I'm not sure. Ding, ding, ding. There goes the bell. All right. Sounds working. Botulism down at the bottom. That was why I harped on that one so much. I knew it was not the questions. Botulism is our number one.
Yeah, because it was like the last thing you think of. It's like, wow. That is crazy. That is crazy because I mean, he was showing something like house sitting where you have a hand tape where he's got his infection. He's not taking care of himself. Yeah, right. Yeah, yeah.
Actually, I had to read on that one. So the red itching skin, you can get seizures. You can actually get seizures with the pesticide poisoning, but you tend not to get that red skin and itching. That's very indicative of actually an anticholinergic exposure. Red, white, and blue. There it is. So I'm actually at the end of my time just because I chatted too long. So that's what I got for you. Any other questions?
You.
Yeah. Okay.
All right. You guys have a great day.
You too.